All right, well, good afternoon, everybody. We are going to jump into today's little presentation on augmented integrative PRP and stem cell treatment. So what does this mean? You'll find out in a minute. Somebody could do me a favor and just type a 1 in the chat so I can know that people can actually hear me out there and I'm not talking myself this afternoon. That would be great. All right, cool. Thanks for the sound check. Jane and Lori and Tammy, we're all good. So we're going to lead into this. I want to get through the content as I put over there in the chat. If anybody has questions, just drop them over there as we go along. And at the end, I'm going to answer as many as I can with the time we have left. But jumping in for those who don't know me, I'm a non-surgical orthopedic doc, and I specialize in regenerative medicine. We'll talk a little bit about what regenerative medicine is for those who aren't familiar with that word or specialty. And then we'll talk about what do I do as a non-surgical orthopedic doc? Well, I don't do surgery, is the obvious tip off there, but what are the treatments we use to help people recover from injuries in a different way, in a different mechanism than maybe people are conventionally trained to do or have experienced in conventional treatment? So that's a large part of what we'll be talking through today. I run a practice out in Tucson, Oro Valley area, and it's called ORIGEN. And our mission is really to accelerate healing. When people come into our practice, they're often injured. They have an orthopedic complaint of some type, bad knee, bad shoulder, something that's not working how they want it to work. And we want to get to the root cause of that as quick as possible, diagnose the problem, and then match the treatment to it so that we can restore quality of life. Really, that is the goal. How do we get you there as fast as possible to get back to the quality of life that you want to be living, and then to help people live that way better for as long as possible? So that's it. There's some people who are really interested in living forever. I'm interested in helping people live really good and healthier for as long as they can. So it's not just an age thing, which I'm going to share on this next slide, because we can look at longevity in a couple of ways. The people that are just seeking to see how far out on the timeline can they live. And most people would rather have the version where they're living really well, not held back by medical problems, medical disease, compromised function, a lack of independence, pain, and all those things that keep them living the quality of life that they want to live, experiencing the things they want to experience. So that's what I'm interested in. Helping you live to 180 is not what I do in my practice. But the goal is to help your joints live as long as they can, because most people would want to keep their own joints if they can instead of replace them. Most people would like to solve a problem without surgery, including surgeons, if they could do that. Okay, so that is what we're talking about, and that's what I do in my practice. Because a lot of people feel this slide, and what some people have called this is the marginal decade. So this span of time where you used to be in pretty good health, but then your health has started to slide. And as your health starts to slide, then you accumulate more medical issues. And then you start spending more of your time in doctor's offices. And then that's what life is kind of about. So you're around, you're living, but you're not really living. You're not having the quality of life and the functionality you need. So what we're trying to figure out, and those of us who specialize in regenerative medicine like myself, is how do we slow down this decline? Right? And how do we stretch out the timeline where you have more healthy years and the amount of time you spend in doctor's office with disease state where we're doing disease management like conventional healthcare is as short as possible? And that's why this graph shows those two lines. The traditional one is the first line that starts to decline, well, way back along maybe 60 years of age. And by the time you're 85, you're lucky to be around. Or the one that, man, we can stretch this out a little bit further and you start to decline a little bit later in life. And the final decline is more steep and only over a couple of years. Like, who would like to get out to, say, 85, 90, and 95 years of age and still feel pretty damn good? And then maybe they have a decline over 4 to 5 years, right? Anybody interested in that? Just put yes in the chat. Can I live longer and have a much shorter decline at the end? Can I live great years out to the end and then have a more short decline at the end? I think everybody would say yes, but apparently nobody in the room. Oh, Paula does. Paula wants to live that way. So great. Me and Paula are aligned, and Lori does too. So, I want to live out there a long ways, but I want to be able to have my functionality, right? I want to have my independence. I want a body that moves the way I want it to move. Because if people have heard some of my other talks, I got, young kiddos, and I want to live out there quite a ways to see what they do in life. And that's the goal. So today, what are you going to learn? We're going to talk about the history, the science, and clinical effectiveness of extracorporeal shockwave treatment. And when I say those things, people conjure up the words corporal punishment and shockwave, like electroshockwave therapy. That's not what we're talking about today. As you'll learn in a minute, this is a different type of technology. And we're also going to learn about laser treatment. So what can lasers do in the body? They can do some pretty remarkable things if you harness the power of what is in these tools and you put them together. And that's the basic physiology. This is the 101 course we're doing today. I'm going to do a more advanced, dig into the science, look at the literature, maybe out there in July for the nerds in the room that want that next level. We're going to do a part 2 to this in July. But we want to talk about the synergistic and compounding effects of these two tools. Why are we using them? Why are we using them together? And why are we using them in this next generation of regenerative medicine? What I'm referring to as AI. AI is all the buzz today, but augmented integrated is what we're talking about. How can we augment, enhance healing? How can we integrate different tools for that healing so that we compound the effects and we get people there faster? And we have a more complete healing so that the duration of benefit from the treatment we're doing lasts longer. So it hits those marks. Get there faster, get back to doing what you like faster, and live there longer. So let's jump in. What is extracorporeal shockwave therapy? It's a non-invasive treatment. It leverages high-energy acoustic waves. Okay, so high-energy acoustic waves stimulate tissue repair, they reduce pain, and they enhance healing in orthopedic conditions. Okay, so that's how it works. It's sound wave that we're pulsing at tissue. So where did this stuff start? So back in the 1980s, this technology was used to break up kidney stones, what we call lithotripsy. Okay, so extracorporeal shockwave therapy was first introduced to break up kidney stones. Why? Because then they wouldn't have to cut open somebody's back and get into their kidney to remove a kidney stone. They could pulse a wave from the outside of the body into the body, break down these calcifications and these kidney stones, and then eventually people could eliminate those and pee out much smaller fragments of that. Then they started taking the application of this forward in orthopedics in the late 80s, early 90s. And the very first kind of big experiment with this is they said, hey, if it breaks up the calcifications, I'm going to just do a sound check here because I'm getting a message from somebody. Can everybody else hear me okay? Maybe it's his audio or his reception, but can people give me a thumbs up that they're hearing my audio okay? I just have one message in the chat. Lori says it's fine. Hey, Dale, maybe something on your end. If everybody else is hearing me loud and clear, then it could be something on your side. So I'm just going to keep rocking if everybody else says loud and clear here. So what they wanted to do with this technology is they said, hey, people have heel spurs. So painful spur on the bottom of the foot, a lot of people can get. And they said, hey, if we can break up calcifications, kidney stones, maybe we could aim it at this bone spur on the bottom of people's heels and it would break down this bone spur. So then similarly, they wouldn't have to do surgery and they could get rid of this painful heel spur. So they took this technology, they started to beam it at these heel spurs in this study. And I think they had around 100 patients or so in this study. And lo and behold, it didn't do anything for the bone spur. So the treatment was an utter failure. The experiment didn't pan out. And they said, you know what, this tool isn't going to be that great for neutralizing and dissolving these bone spurs that people had at the heel. Well, here's the twist to the study. All of those people had pain relief. So their heel pain that they were limping around on got better. The heel spur was still there, but their pain got better. And so what it told the people at the time in this study, or informed them of, is, you know what, it is not the heel spur that's the issue here. It's what's going under the tissue that's attached to the heel that's pulling on the bone and stretching out that heel spur. Okay, so that's how a heel spur actually forms. It's the tissue attached to it, namely the plantar fascia. So the plantar fascia is pulling and pulling and pulling on the bone, and you're literally pulling the shell of the bone, what we call the periosteum, further and further away, and it's calcifying and causing a spur. So again, the people at the time said, well, it's not useful for the spur, and they kind of dismissed it. But smart people said this technology has some promise here in orthopedics. Okay, so off they went to start applying this to other orthopedic conditions to say if we could stimulate healing and pain relief in one tissue, can we apply it to other things? And so they started applying it to other things. So when we look at this in orthopedics, they also started applying this to early on to the treatment of non-union fractures. And what a non-union means is that if you break a bone and it's not quite gumming up and forming a callus so that bone comes back together, it's called non-union. It's not united. And so they started to project this sound wave to stimulate bone healing, where traditional methods had failed, meaning wait and watch, walk around in a cast, do something short of surgery, or even in people that maybe had surgery and kind of refractured the area or didn't have a union, they started to use this technology to beam a focus of extracorporeal shock wave sound energy at this bone to stimulate the bone to grow and stimulate it to heal. So they started to just apply this then across the board to other things. I mentioned plantar fasciitis. I started using this in calcific shoulder tendonitis. So this is where you could get calcium deposits in the shoulder. Lateral epicondylitis, which is a condition that we now call tennis elbow on the outside of the elbow. And so they started to apply this against many kind of stubborn musculoskeletal orthopedic things. And what they saw is that very quickly, people would have pain relief. And over a period of time, those who had failed a number of other treatments, like rounds and rounds of physical therapy or cortisone shots or other things, again, this was predating a lot of the traction with things like platelet therapy and stem cell therapy, but they're getting a lot of these stubborn injuries to heal by beaming it with this sound wave. And we're going to talk about how this works and why it works, the physiology in a minute. So let's change gears and talk a little bit about laser. So laser came on the scene probably in the early 2000s. There's different categories of laser. We'll get to that in a minute. So high power laser therapy became more prevalent early 2000s. There was one landmark pivotal study by Mester and his group of researchers that they started to use this in certain musculoskeletal conditions, such as tendonitis, because it's a very stubborn injury to heal, whether it's, again, at the elbow or the Achilles or plantar fascia. So different tendon attachments or fascial attachments, and they started just treating it with this laser. We'll talk about what laser is and why it works. But they started projecting it at this, a very kind of innocuous treatment because it just feels like a warm massage on the body. And it stimulated healing in these tissues, and people got reduction in pain very quickly. And it promoted tissue repair because these people had already failed a bunch of other treatments. And now they just applied this in the study and only this to see if they could get them better. And they got a lot of these patients better. So just like shockwave, they started to study this in different realms of musculoskeletal arenas and injuries and got improvement with a lot of these stubborn conditions. So if we dig deeper down into the science now of each one, we'll take shockwave first. So shockwave and how it works for tissue healing, it's delivering a focused shockwave, so a sound wave. So it's a percussive tool, and I'll jump to the next slide and then I'll jump back. So inside of this tool, there's a projectile, and there's compressed air that's coming up through this tube, and it's shooting this projectile to the end of the tube, and then it transmits that impulse through the applicator, which is the tip of the device, and you're applying that applicator to the tissue. Okay, so what does it do? When it's pulsing that tissue with a sound wave over and over, it causes micro trauma. So microscopic trauma to the tissue and stress on the targeted tissue that stimulates the body's natural healing response. So if you exercise a muscle, anybody that's lifted a weight in their life, you're actually causing micro tear and trauma to the tissue, and then the body heals from that and it gets stronger. There's an adaptation to that. So the first way this is working is a mechanical stress of this tissue to stimulate a healing response. Then it's increasing blood flow. So the mechanical action will increase the circulation of blood flow into that tissue that we're pulsing with that sound wave. If we can increase blood circulation, we can get more oxygen in, we can get more nutrients in, and therefore we can heal tissue. We need blood flow, we need nutrients, and we need tissue that's kind of gummed up. Think about it as scarred tissue to break down and be more elastic and more normal again. And we're doing that because it's stimulating the release of these growth factors in the environment and other molecules that come into the area to enhance cellular repair, like stem cells. So it can reduce pain at the same time. It's a weird sensation for those that have had it. Has anybody had this treatment that's in the room today or hanging out on the chat? It's an interesting sensation. So Lori's been in the office getting some treatment, but it's kind of a pulsing, focal, almost like massage. And we want to keep that pressure and the sensation like somebody's getting a massage and you're getting on a trigger point that, man, it needs to work, but it's kind of like a hurt so good kind of feeling. So when we're doing that, we're stimulating nerve endings. And we kind of almost overwhelm the nociceptive, the nerve ending inputs, and you're relaying all these signals back up to the brain to process, and it diminishes pain pretty quickly in some of the areas you're treating. So we get this kind of initial four-pronged approach here: mechanical stress, causing that tissue to get stronger, increased blood flow, the cellular response now we're getting by bringing in oxygen and nutrients, and then growth factors and other stem cells that are migrating to the area, because we're inducing a microtrauma, which induces the body's immune system to come to this area and stimulate healing, investigate the problem and stimulate healing. So this is a device, this is the fancy pulses and pressure, and it's measured in bars. We're not going to get deep into that kind of nitty-gritty stuff today. We're going to keep this high level. This is what the device looks like. So it's very compact unit. It has different applicator tips that we can use if we're trying to get a more focal area or a more diffuse area. And you're applying this directly to the surface of the body with some conductive gel. And you're pulsing the tissue at a high frequency, 2,000 to 3,000 pulses in a very short amount of time, on the order of 5 minutes or less. And so if we look at what's happening there, we're giving it high pressure over a short duration of time. So we get this peak pressure, this rapid rise, so up and down, instead of like this slow, methodical, deep tissue massage. You're getting high pressure, very short duration, and you're keeping a lot of energy in the tissue. Because the key to all of this and changing the tissue is how much energy can you get into that tissue to induce those physiologic responses that I just shared. And it's got to be targeted. And you get this kind of too diffuse on an area and you're trying to treat a wide span of tissue on somebody, it's not going to do the job. But this is where if somebody has a focal issue over their elbow or around their knee, or around their shoulder, we can treat all that territory very quickly in a matter of minutes and get a high amount of energy into the tissue. So again, biologically, what's happening here? So again, mechanotransduction is the fancy scientific language for this, but mechanical energy is converted into biochemical signals within the cells. So we get this cell response, we actually get gene expression, protein synthesis, we get cell proliferation, which is growth of new cells. Because our body's always turning over cells. 1 million cells a second, as we're talking, listening today, are turning over in our body and being replaced by 1 million more cells. So the more activated we can get this site with cell turnover and proliferation, the more we can stimulate healing of the tissue. Now, the cool thing about this is it drops inflammation in the tissue. Okay, so pro-inflammatory cytokines, this is the chemical soup I talk about a lot that's in the tissue or in the joint when it's flamed up. And it starts to tamp down that inflammatory environment, okay, by increasing anti-inflammatory type of chemicals in the body. We think about this as endorphins, like people get when they're running, the body's natural pain relievers. So because that treatment is stimulating the sensation in the tissue, you get a release of those endorphins and enkephalins and the body's kind of natural pain relievers. Then we look at blood vessel formation. So what this is shown to do is also stimulate new blood cells, new blood vessels. So very small blood vessels, very microscopic capillaries that feed the tissue. We call it angiogenesis. So if you can get more blood cells, you get more pipelines coming into the problem area, you have more oxygen, you have more nutrients, and you have more things that come from inside those blood vessels like VEGF and other angiogenic factors that start to stimulate more blood supply to that tissue to enhance the repair. What you also get then, by nature of stimulating what we're aiming this at, for instance, fibroblasts, those are for repairing, or those are the cells that make up our tendons and our ligaments and other connective tissues. So if we're inducing more change in the fibroblasts, because our body's constantly remodeling this tissue, we can remodel it faster, okay? We're enhancing the collagen production, and collagen is like the little tensile fibers within our ligaments and tendons and our cartilage structure. So if we can induce more collagen production, we have better structural integrity. We have better flexibility and elasticity of that tissue, and therefore we're less likely to break it again. Once we get healing and we reestablish normal tissue elasticity, healthy tissue, not scarred tissue, not inflexible tissue, then the likelihood of recurrent injury is lower. And that's what my colleague, Dr. Copeland, has showed in his data up with his group in Toronto, is that when they've used these technologies and they've tracked people over time, the recurrence rate of recurrent injury is much lower. And then finally, that nerve desensitization. So when our body's in pain, the area gets sensitized chemically. And so that's what I mentioned. We're releasing these pain inhibitors, endorphins and enkephalins there. And as I mentioned earlier, we can get some calcific breakdown. So if we have little calcium deposits, because when we tear tissues, we bleed, and inside the blood is calcium, and calcium can be left behind in the tissues. And some people can get very painful calcific deposits in tendons. And it's a very hard condition to treat sometimes, just with physical therapy, mechanical type of tools. But this is a different mechanical type of tool, just like those kidney stones that can be pulsed and broken down into microscopic fragments that then can be reabsorbed by the body. So it's a really neat mechanism for those type of injuries, because they can be quite painful. And some of them can lead to surgery where they got to cut open the tendon and kind of squeeze this stuff out of there. And it looks like dried out toothpaste when you look at it in the OR. So I saw some of that back in the day in my training. So if we get over to laser now, and we talk about the physiology here, the term we're using for this is photobiomodulation. So what does that mean? It means that photons, so a laser is light and actually a particle, which makes a photon, that's absorbed at the tissue, really sub-tissue cell level, and really subcellular level at the mitochondrial level. That's about as deep as we're going to get in the science today. So mitochondria are the energy-producing powerhouses of our cell. And laser induces a change in the mitochondrial chromophores by hitting this enzyme. What does that do? It increases the production of ATP, which creates energy in our body. That fuels the cellular processes in the cell. So we are a walking chemical sack of reactions, right? Billions upon billions of reactions are happening every second in our body and every cell in our body. And we're revving up that process to work better, by which it can enhance that cell proliferation and accelerates the tissue. So mitochondria is charged up. There's more energy in the cell. Think about it like yourself. When you got a great night's sleep and you're well rested and you have a ton of energy, how much you can do and produce in a day. And then think about a day where you slept really lousy and got up and how productive you were in the day. So it's the same kind of concept. If we can charge up the mitochondria, we can charge up the cell reactions, we can charge up what the cell is doing for the tissue, and then we get more repair. So the thermal effects, so again, this is creating heat in the body. So class 4 lasers, you have to register these with the state of Arizona. You have to be trained to use them, because there is a thermal effect where you can actually injure people if you don't know what you're doing with a class 4 laser. So it enhances blood flow. It improves lymphatic drainage. So people that have just like swelling in the soft tissue, sometimes it's not in the joint, but it's around the tissue. Well, our lymphatic system is the sewer system of the body, and it drains that fluid away and cycles it back and out and into our digestive tract and urinary tract to eliminate it. But if our lymphatic system is kind of stagnant, we can't cycle the waste products and the cellular trash away from the tissues, and it accumulates, and that stagnation there causes more inflammation and chemical sensitization. So it improves the lymphatic drainage of the body when we project laser at it. And very quickly, for people that have pain and muscle spasms, it can be an amazing tool And very quickly, in the matter of a couple of minute treatment, it can alleviate muscle spasms and pain for people at the target tissue site. What does this thing look like? It looks like this device on the left, so it's very compact. Here's us, day one of training. I jumped on the table first to experience this. And this is Dawn treating my elbow because I'm working through a little elbow dealio. And this is our guy in the back, Craig, who trained us. We have got our super cool sunglasses on so we can protect our eyes with a laser. You need to wear these cool sunglasses. But the mechanisms of this, again, increased energy production, ATP equals energy. That's all you need to know. Excites the energy production in those cells. Nitric oxide release. Okay, this is where we get dilation. Okay, so if people take nitric oxide, what does it do? It opens up the blood vessels. It's a vasodilator. If our blood vessels are opened up more, we can get more blood flow through them. More blood flow equals more oxygen and nutrients equals faster healing. And then angiogenesis, it has the same mechanism or the ability to produce the same mechanism, which is actually formation of new blood vessels to enhance the healing to that tissue. And then anti-inflammatory effects, very quickly with the laser. You know, when we put this on somebody in a couple of minutes, it can reduce inflammation in that tissue and decrease pain and swelling. So it's great for arthritic conditions, tendinopathies. We'll get into some of the specific conditions in a minute. And then collagen production. So again, we see both of these tools having some similar actions, but through different mechanisms. So decreasing inflammation, increasing healing, increasing collagen production, which those of you that are in the aesthetics world know that lasers are used quite often for aesthetics because we can stimulate these fibroblasts and collagen production and turnover of cells in the face and target tissues where, you know, gone are the days of doing these major facelifts, and they're using a lot of lasers to tighten up people's skin now on their face and make it look more youthful. So really cool stuff there, not what we're using for in my practice. So this is why I'm so bullish on collagen resupplying in the body, and why I recommend my patients with joint issues, with tendon issues, with ligament issues, to be taking in some endogenous or some exogenous outside the body collagen, because your body's own ability to keep collagen around depletes about 1% per year after age 30. So if we're depleting out collagen, the tissues are less flexible, less elastic, more likely to break, tear. If we're using these tissues to induce better collagen and supplying the body with nutritional collagen, now we've opened up the channels, the blood flow, to deliver those nutrients to the target tissues. So that's why I'm so bullish on taking this stuff and have for years. Because what we're dealing with is all of these inputs. When we're talking about a tissue that's damaged, we're talking about the cells that make up that tissue. And there's all these inputs. If we're in pain and there's inflammation, there's all this chemical stuff. And then we're aging and we're traumatizing the tissue somewhat using it. Some of us overusing it, or there's just a certain amount of wear on it daily. Then it starts to have these compounding effects by which we kick off all these inflammatory cascades that are down below, which, again, we're not getting deep in the science today. We'll save that for another day. This is as deep as I want to go for people in the audience that have arthritis, to really understand the mechanism that's going on in a knee, in a hip, in a shoulder, wherever there's arthritis. So depicted over here, the blue balls stacked up on top of one another are the actual chondrocyte cells. So these are cartilage producing cells. And up here at the surface level, we start to get damage, okay, over time, by which we kick off these molecular patterns, these damps. Those go over to the lining of the joint, and they kick off this humoral and cellular inflammatory response. What that means is we kick out fluid, okay? So the synovial lining makes fluid, and inside that fluid, there's chemicals, cytokines and chemokines. And these other things, matrix metalloproteinases, these MMPs. And as this stuff cycles and spins, this is where it's a chemical loop that starts to degrade the knee or the hip or the shoulder. So people are often told, oh, it's wear and tear, and that's all it is. And it's not, it's chemical. It's more chemical than wear and tear, even in the early stages, because we know people can have pain for many years that predates the findings of cartilage loss on an x-ray. But once we can see cartilage loss on an x-ray, even in grade 1, you've lost 10% of your cartilage. When we see a grade 4 knee, that means you've lost more than 65% of your cartilage. So in the very early phases, when we have an injury to the cartilage surface, we start to loop this mechanism. And it's why if we pour steroids into here, it will shut this off temporarily. But then it will just cycle back up after the steroid effect dissipates. So again, that's why cellular targeting of these injuries, like shown on this slide, using some type of biologic agent, it works much differently than a steroid. And it can inhibit that chemical loop, turn it off, by which the body now can actually get to work healing and cycling those cells to heal. So if we're inducing it then with tools like shockwave and laser to stimulate it to heal, and we're putting things in there like PRP or stem cell inside the joint itself where the cartilage is breaking down, well, now we're starting to stack multiple things that can prevent this right here, which is if it goes down this pathway long enough, it leads to cartilage loss. We're talking about saving one's joints. So we want to stack all these things around it that shuts off this chemical loop, this degradation process, so that we can halt and slow down the aging of one's joints. And that's mechanistically how we think stem cells and PRP and this augmentation is working. We don't have anything yet that completely reverses this, sends things back completely the other way. If somebody's in grade 1, 2, 3, can we back them up from a 3 to a 2, a 2 to a 1? Look, there's things that are published in the literature that show before and after MRIs with healing of meniscus tissue and cartilage injuries. But when we get big defects or we get significant loss of that cartilage, especially in an older patient, it's hard to restore what you've lost. The goal is to shut off the chemistry so you feel better and slow down the rate at which it ages and you lose the rest of your cartilage. For those in the Zoom room that don't want their joints replaced, that's really what we're trying to do there. So if we look at clinical applications, let's dig into some of the places we're using this. So tendinopathies. What a tendinopathy means is that the tendon is no longer healthy. A tendinitis in an early stage is the tendon's inflamed. As we move along and have that more chronic condition, it starts to change the tissue itself. The tissue gets stiffer. It even has scar tissue within it. It becomes less flexible. And this is why these things become chronic and stubborn and can recur over and over and over again. So golfer, tennis elbow, Achilles tendon problems, plantar fascia would be in this box, rotator cuff tendinopathies, or hip tendinopathies on the side of the hip. So we know mechanistically how this is working now, reducing inflammation, enhancing collagen production, alleviating pain. It's going down through these pathways that I mentioned over here on this slide, like these IL-1 and IL-6 interleukins. It's decreasing C-reactive protein, which is an inflammatory chemical. But if we look at what's going on, say in what I call a pickleballer's elbow, because that's what I see more often than a tennis elbow, it's where these muscles come in and attach here at the location on the outside of the elbow, we start to break down this tissue. And it looks something like this. So it starts to tear away. We have fiber tearing of the attachment to the bone. And when we have that, we have pain and we have less power in the muscle. And the more we try to grip and use our forearm to grip things and flip our wrist like a backhand, you're going to pull on this muscle, which pulls on this tendon attachment and tears these little micro tears along the bone. And that's why anybody that's had this feels pain along this bone that can be exquisitely tender, and it can radiate down their forearm. And this can be on the inside of the elbow as well. If we click over to rotator cuff injuries, there's a few different mechanisms that happen, but it's a tendonitis where the muscles coming through here start to get enough friction kind of wearing against the bone through faulty mechanics or just overuse that we start to fray the tendon some and it starts to get inflamed. Then we can actually develop a tear in the tendon. We can also get something called an impingement where the bursa gets inflamed and starts to impinge the shoulder mechanics when you try to stretch your arm up overhead. Then we get the progression of that, which is we start to get into different types of tears. So we can have a very small tear in the supraspinatus, or we can start to tear away more tissue, and then we can get a retraction where it actually pulls off the bone. And this is where some people are told they need rotator cuff repair, depending on your age and the severity. But there's good studies published in this that in these tools with extracorporeal shockwave and laser, that if we catch it in these earlier stages of either tendonitis or tendinopathy or even small tears, that we can stimulate healing and repair there. So if we jump onto cartilage injuries, which a lot of people are dealing with, maybe some type of osteoarthritis, and what I'll lump in there is meniscus injuries in the knee or labral injuries in the hip or shoulder, because that's a different type of cartilage called fibrocartilage, but it's a very stubborn tissue to heal. But again, we learn the mechanism now. If we project extracorporeal shockwave, we'll just call it shockwave at this, it promotes cartilage repair. It's been shown to reduce the subchondral bone sclerosis that we can see on x-rays and improve the joint function, because if there's less pain and we're getting some repair, people feel better. And then the laser, again, is going down to that cell level, deep into the cells, the chondrocytes and the mitochondria, to produce that action that I shared before, which is rev up kind of the energetics of the cell to heal. So it can reduce pain very quickly, increases that blood flow, increases collagen production, by which things start to heal. Because when knees start to look like this, which I see quite often, not so much normal knees, but these knees over here where we start to wear patches in the cartilage, we get early breakdown of the cartilage or the meniscus tissue or the ligaments in and around the knee. These are great tools that we can use on that to stimulate healing. If we look at meniscus tears, there's all different types of tears in the meniscus depicted on this slide, just based on the orientation of where these tears are in the tissue. But again, good data to support that with enough energy. So you got to have the right tool here, okay, the right technology to penetrate these tissues, to go deep enough into the body to get to these tissue sites to stimulate repair. And we're going to talk about this in a minute, because not all technology is created equal here. There's a lot of things being marketed in this space now, and lasers have been around for a very long time, and there's all different powers of laser. But if we move along to bone healing, we mentioned that a little bit, and that's where we're using a much more focal extracorporeal shockwave therapy. So you want to either change the applicator tip or using what they call a focal extracorporeal shockwave, and we'll kind of split out this terminology in a minute. But they can project that down. If we got to get down and inside of a bone, that's a much deeper penetration that we need in the tissue, depending on what our tissue target is. If it's very superficial, like a thumb joint, we don't need as much energy. If it's a hip joint, you need a lot of energy to get down to that. So deeper the tissue, the more energy we need. Low back pain, good data here to show that can really help with pain relief. People that have chronic low back pain that we think is muscular or joint related. So technical considerations. I want to pivot to this because this is just high level stuff today, but the type of shockwave matters. There's a couple different types of shockwave. I'm going to go to this slide and then I'll go back. So extracorporeal shockwave therapy can be broadly categorized to radial or focused. Okay, so if we jump to radial, what that means is that the pressure waves spread outwards from that applicator tip. Okay, and it's generated pneumatically by air, and it's handheld device. So this is the unit we have. And the applicator tip is going to allow us to get to more focal areas and deeper, or a broader area. So anybody that's had the treatment, they'll notice that, Dawn or Joe, who are my athletic trainer gurus doing this, that they're changing the tip when they're treating people. They're treating some areas with one applicator tip, and then they're changing to another one for that reason, to get deeper penetration more focally, and then spread it out more diffusely over the tissue. So this is a great tool for superficial soft tissue injuries, ligament, tendon, fascia, deeper musculoskeletal pain, okay, if we're talking deeper structures, hip, knee, shoulder, and these tendonitis, tendinopathy situations. The the focal shockwave, these are really deep-seated conditions. Think about bone healing, non-unions with those fractures is the most common reason people are turning to this type of shockwave to really go after deep structures in the body, or a very hard thing to heal like bone. Okay, so that's the primary difference between the two. Most people nowadays in the orthopedic world are using some type of radial shockwave more than they're using the focal, but some people are using both because of the nature of their practice if they're treating a lot of bony type of problems. So the energy levels, as I mentioned, adjustable energy level is key for two reasons. One, for the comfort of the patient, because we want to keep this at a comfortable level during the treatment, like a 4 or 5 level, not 10 crying on the table. Like I've heard patients come in and tell me when they've had these treatments elsewhere. It should never be that painful. And then the frequency of shock waves, okay? How many shock waves can we put, how much energy can we put through the tissue in a short amount of time matters. And then the focus, as we talked about with those different applicator tips. So technical considerations of lasers, this slide is really small, so everybody's going to be squinting at it now, but this talks about the class of lasers, FDA categorization. So the class of laser, okay, we're using a class 4 laser. That's the most powerful laser you can use in a medical application. Old terminology, people talk about cold and hot lasers. Cold lasers were less powerful lasers. Hot lasers were considered things like used in an operating room to actually burn or cauterize tissue. So that's where the cold and the hot laser stuff came to be. That's old terminology. Nowadays, people don't really use that terminology. We're talking about class of the laser. What class laser are you using? Did you buy a little laser pen on Amazon and you're shooting it at your elbow and you think it's going to heal tissue? It's probably not. That's a class 1 laser. It doesn't put off enough wattage or power to do anything in the tissue level. It's not going to penetrate anything because the skin absorbs laser. It absorbs light. The melanin in our skin diffuses some of this. And that's why you need a more powerful laser and more concentration, especially in people that have darker skin. It's a consideration in the laser power and the depth at which we can penetrate. So all of those things got to be manipulated in the context of doing proper laser treatment. One, you have to have the right type of laser. Should be a class 4 laser for this kind of application we're talking about today. And then it has to do with the wavelength of light that can be produced by the laser. And it's usually operating in this near infrared range. Somewhere between 800 and out to 1,000 is optimal for deeper tissue penetration. Okay, again, depending on what we're treating. And coherence just means we got the laser traveling in phase with one another, which allows more focus energy to kind of come like wave after wave, like ripples kind of across the water. And collimation just means how tightly can we kind of focus things down, or how broad is that spreading out. So all lasers are different. Anybody that's exploring laser therapy, you have to ask a lot of questions of the person doing it to understand what type of laser do they have, what is the power of the laser, because a $50, $100, $200 laser gadget on Amazon, number one, is probably counterfeit. It's not even laser, it's light arrays, LED lights, which have healing properties. So red light therapy can be beneficial, but it's not a laser. And marketers will commingle these terms to confuse you so that you don't even know what you're buying, getting, or otherwise. So you really have to know what you're getting, is the short of it. So now let's bring it full circle. Why do we combine these two? Because if we combine these two and we stack them right on top of another, okay, the unique mechanisms they have complement each other. Okay, so if we're looking at enhancing tissue repair and pain relief, this is the friends with benefits, right? If you put these two things together, we have the sound wave inducing the microtrauma, which promotes the blood flow that stimulates the cell regeneration and reduces pain. So it's kind of like the good cop, bad cop, right? Or it's the shock and then the ah. When you shock the tissue, it's not uncomfortable, but it's not something you want to have done for minutes on end. And that's why these treatments are very focal and they're very short, just a few minutes. Because it agitates the tissue. It's causing microtrauma. It's on the edge of being like, oh, that's not super comfortable. But it's done intentionally to induce the change in the tissue. And then the laser follows it, which feels great. And everybody loves the laser. Anybody that's had the laser in the chat room, just say, do you love the laser? Everybody says yes, because it's like, okay, do the rest of me now. Because again, with a high power laser, the treatments are very short too. So when we stack these together to treat one body region, it may only be, yeah, Lori loves the laser. Yes, I love the laser too. I bought these selfishly for myself to use. But the treatments are very short. So then some people struggle with that. They're like, holy cow, like the whole treatment start to finish was like 10 minutes for using both tools and both applicators and laser. Yeah, because it's about how much energy, okay, we can get to the tissue in the shortest amount of time. Why? For the timeline I showed. Everybody's got stuff to do. So I want to get the best treatment as fast as I can. Massage therapy is a little bit different. You're paying for the minutes to get more work on more tissue. And this is kind of less minutes to work on the tissue because it's about the amount of energy. So it's cumulative energy, frequency of treatment, which is usually 2 to 3 times a week. Some people, we can fast track them and do them daily. Typically, it's 2 to 3 times a week. And then it's cumulative dose that we need to get into the tissue over time to induce the effect. So one treatment, you could feel some change and say, oh, I feel better because I've changed the nerves and the sensitivity in the tissue. But to really change the tissue structure itself, it takes multiple sessions to do this. You know, the data will show anywhere from 6 to 12 or more sessions, and the sweet spot's probably around 10, depending on how chronic the tissue problem is. So we kind of run on this with 10 sessions as kind of our framework a couple times a week right now. So bringing this full circle, because then I'm going to open it up for some questions here. And if anybody has any questions, start typing away over there in the chat so I can see them. But when the body needs to heal from an injury, it's always going to walk through these same steps. The simple path to healing and regeneration your body possesses at an innate level, it has this capacity, it's designed into your programming, is when you're injured, it gets a little bit inflamed. What we're doing now with this tool is we're modulating that inflammation in a healthy way to reduce the painful chemicals, but enhance the good part of that inflammation that stimulates healing. And then we can accelerate the regeneration, repair in the tissue and walk people up the steps towards more complete healing, is how it's working on the very simple level. There's 4 steps. We're injured, we're inflamed, we start to regenerate and repair that tissue, and then can we actually get it completely healed? And a lot of people can't. It falls short of the mark, either because of age or because of demand on the tissue. They keep working at it, doing physical therapy, modifying their stuff, trying to get at it, but it never quite heals. And these can be game changers to stimulate healing in that tissue that's been stubborn to heal. But the body's always going to work through this principal pathway. And what we're doing and what we want to do is stack the things on top of it to make it go faster and more complete, so that we don't recurrently injure the thing because it hasn't quite healed the first time. Because we want to get people from hurting to healing in a matter of months. I had a woman in the office yesterday, I can't see everybody in the chat, maybe she's on this today, but she gave us a very nice card to message to our team because she was hurting for years. In a matter of months, with the treatment we did for her, we got her from hurting to healing, where now she's back to activities that she couldn't do before, didn't think she was going to be able to do again. Now she's strengthening up her body, building her capacity back to do more. But in a very short amount of time, we took her through this sequence and her body healed. So our bodies all possess this innate, hardwired mechanism to heal. We're just putting more energy into the area that needs to heal. With cells, we're taking cells and resupplying the area that needs it to heal so that we can stimulate more healing in that tissue. Because this is what it looks like for people. After we treat them and say we induce a change with an injection of PRP or stem cells, the body goes up and down and up and down. Everybody that's had this treatment knows it's good days, bad days, not so good, then a good day. But collectively, over to several weeks of healing time, 6 to 8 weeks being the normal healing curve, people get better, right? They establish at the top of this graph a new normal. Like the lady the other day thought, I'm not going to ever be back to that normal that I used to know. And it's a great feeling for people then to resume that life where it feels better and now they can do things. Because now when we combine these things together, you've kind of learned how these work today. Think about the shock wave as a stimulus to restart the healing process. A little bit of micro trauma in the tissue, followed by the laser, which stimulates more blood flow. So think about it, a little bit of tissue trauma at the micro level, stimulating new blood flow into that tissue, and then laser really opens up the blood flow channels to bring in the oxygen, the nutrients that we need to heal. And when we stack this together with things like PRP and stem cells, I mean, it's just the game-changing effects of stacking them all together, right? Because now we're delivering powerful cells into the area that can stimulate healing. Now we're boosting the effect of that healing and regeneration with these other 2 tools. And that's why I say, hey, the next evolution of this stuff is this. right? It's why I brought this into my practice after studying it for about a year, and then going out to find one of the best in the world who's done this for decades, Dr. Copeland and his group up in Toronto, which we thank every day for their support getting us started with this stuff, because this is now another tool in our box that we can help a lot of people with, whether they get injections or not, or, hey, this is a great tool if people are somewhat needle phobic and they don't want to get injections. We could use these tools now to stimulate some healing in these tissues, because his group for a long time wasn't using PRP and stem cells. They were just using these tissues, laser and shockwave and proper biomechanics, to treat a lot of their patients and high-level athletes. Now, of course, over the last several years, we've been incorporating PRP and stem cell and now putting it all together. So those are the tools. You know, the shockwave is really preparing that tissue to heal, and the laser is enhancing that healing effect. It's the easiest way to think about it. Okay, preparing that tissue to heal, stimulating it, just like breaking tissue down a little bit when we work out to get it stronger. And then the laser is going to open up the blood flow to that. So in conclusion, wrapping this all together, creating a multimodal strategy leverages the strengths of all those therapies. The collective cluster of that is greater than the individual parts together. So we're going to get enhanced tissue regeneration with that. We're going to get enhanced pain reduction with that. We're going to get faster functional recovery for patients than they could with any of those tools alone. But it gives us different tools now, depending on the patient, what their preference is, or the severity of the injury or the chronicity, how long it's been there. We may not have to do cellular treatments on tissues. We could stimulate it with this first. Or for somebody who's had cell treatments, we could come with this afterwards to stimulate more healing. So it really gives us a lot more flexibility in our treatment. And in closing, I always share this detail that I've mentioned it a couple of times already. These integrative, what I call the augmentative integrative, the AI treatments now, they're all based on the fact that the body has an incredible natural ability to heal itself. When we set up the right conditions in and around our body, right? When we're health-minded and we put our health at a high value and we do the work daily, but when it's given the right tools, or in this case, when we apply the right tools, we can really stimulate the body to go fast. So the question for a lot of people out there is like, are you really chasing down the life you want to be living? This is an ad I ran at one point, and I dug it out of my archives when I was working on something. Are you really chasing down the life you want to be living, right? Are you doing all the things out there daily with the time you have? Because that's the thing I'm most conscious of now. I'm 48. I don't consider myself old, but I think about time more than I think about other things in my life. Where's my time going? How am I spending it? Am I doing the things I want to be doing and chasing down in life? Or is kind of the clock chasing me a little bit, that I'm putting off these things that I want to do? Or, hey, I'm not investing in my health the way I should be to get my body in a better state to go do all these things I want to do with my young boys as they grow up. And I got to stay even stronger and fitter and faster if I plan to keep up with them while I age out and they age out, right? So the path to getting the body to heal starts in your mind, right? Anything we want to accomplish in our body, we have to visualize and see it in our mind first. And we got to have those goals concrete and crystallize that this is the why I'm doing this. This is the next thing I want to do when I'm healthier. When this joint thing is solved, we have to have that as your anchor, or you're never going to do the work. And a lot of people never invest in their health because of it, because they just haven't found that deep enough reason to kick them in the pants to go do it and get up and do the work that they have to do to get healthier. But if we can activate the body then with some tools, really targeted, we can stimulate the body to heal, and we get a ton of people better with this. And every week I have walking proof of that coming into my practice with people that have stumbled through so many different arenas of healthcare, conventional and otherwise, and haven't found the solution. And this is not going to be the solution for every patient. And so the only way we know it can be the solution for a patient is to meet you and know you and figure out what you're trying to do and see if it's a good match for these treatments. So anybody that's new to my practice, I'm scanning names and I see a lot of patients in the room today, but people that may have been introduced to this that aren't a patient, the way we get started is called a discovery call, where people can get on the phone with somebody in my office to just review your case, totally complimentary. And we figure out is this a treatment that can match the situation you have? And if it is, then off we go and we get you into a consult and we really dig down and get a clear diagnosis about the problem and then match the right treatments to it, because we need to do the right thing at the right time. So speaking of time, I'm going to leave a few minutes here for question. Thank everybody who took the time to be on this today. I'm going to start in over here in the chat, and I'm going to run through as many questions as I can with the time I have today. So let me back up here through the chat and get to the start of the queue here. So one question I had, is the treatment applicable to sciatic pain? So yes, it can be. So there's some good data actually looking at carpal tunnel, median nerve in the wrist, and using laser, and then they expanded it out to look at other laser treatments. But it is kind of one of those dicey propositions sometimes, because when you're stimulating a nerve with a laser, although we're promoting blood flow around that area, we can agitate the situation a little bit too. So it is one of those test and feel how it goes situations that can be done. There's published data for sure that shows this can work for nerve injury, nerve inflammation, which is what sciatic nerve is, being pinched down in the seat of one's pants, and can be used for that. And typically laser is going to be the tool there that we're going to approach it with more than potentially shockwave. Next question, does this combination have a track record of success with TMD? So I'm assuming this is temporomandibular dysfunction. Yes, Wanda's shaking her head. Yeah, I mean, there is data for this in those joints, the small joint in the jaw here. Temporomandibular dysfunction is an area that I stay out of. I'm not an expert in it. Dr. Miraflu here in town runs tmjcare.com. She's a doc that I refer to, so tmjcare.com, I believe is her site, and she's been wonderful with our patients to look at different treatment approaches there. A lot of it's starting with mechanical alignment, and people are like, yeah, I've been there, done that. And then she has a lot of other tools in her toolbox to use with that. But certainly these tools can be applied for that. I wouldn't be the one to do it because it's not my expertise in the office, and I don't like to guinea pig my patients. I want to use established protocols for things I know to give people the best results. But a good question. Yes, you're welcome. So I think it has some application there. And I don't know personally if she's using some of this in her practice or not. But she's been really great kind of walking other patients of mine through what other things can we use to really fix that dysfunction there. Paula has a question about how soon after PRP do you begin stacking this treatment for your patients? Yeah, there is a waiting time frame there of about 2 weeks. Similar to if I just do PRP as a standalone treatment, we kick off the body's kind of inflammatory response when we do cellular treatments like PRP. Typically, we're going to walk the body through 3 to 5 days of achy pain from the treatment. People clear that, but the first 2 weeks are what's called the inflammatory phase before we get into what we call the proliferative phase, which is where the body really starts to heal. And then 6 to 8 weeks out is where the body gets stronger. So typically, we're going to time our PRP, or sorry, the shockwave and laser approximately 2 weeks post-cellular treatment. And what it could look like for people is prepping with the shockwave and laser for a handful of sessions, then getting their cells, then resuming the rest of their treatment following. Or we can do cells and do the full run of treatment later, because people are going to be healing up through that over 6 to 8 weeks or 12 weeks. As long as we're kind of intercepting that curve while the body's healing, we can accelerate it more with those tools. Next question is from Judy. Judy says, can this be a treatment after having steroid injections in the same area? Yes, it can be. You know, there's a waiting period there that we want to hold off for at least 4 weeks because steroids can weaken tissue. So if we've weakened the tissue somewhat, now I get in there with a sound wave and I pulse that thing at a high rate with a high amount of energy, there's potential there to actually injure the tissue, potentially rupture a tendon. And so we got to have a holding period. Usually that period's about 30 days if somebody's had a steroid injection in a specific area we're treating. And Julie says, what if any research is there for someone with EDS hypermobile disorder, have already been through stem cells, PRP, and prolo, have very fragile ligaments, and apparently defective collagen? You know, Julie, I'd have to dig down into that in the research. I haven't looked that one up specifically in the applications for that, but a hypermobile disorder, as people don't know, fragile ligaments, it has to do with the elasticity in these ligaments. So people that have hypermobile disorders, they are the Gumbies of the world, where they stretch more than the average person. And when we stretch this tissue more than the average person, we can tear the tissue. And a lot of people have a lot of challenges with this because they have a lot of elasticity that takes the joints to like a limit and then beyond, and it kind of leans on the joints different mechanically than the average person, so it can put a lot of stress into the joints. So the treatments there, such as stem cells or PRP or prolotherapy, have been targeted at those ligaments to induce a strengthening effect. And there is some kind of genetic variant with, as she mentioned here, the collagen and the collagen types that become weak in that set of diseases with hypermobile syndromes. So I don't know. It's something that I'll make a note and come back to and see, is there good data to support this from a healing standpoint? Healing's healing. So if we're inducing healing at these target tissues, it's going to stimulate some healing. The question is, will it translate to you feeling better if it's pain relief, or what a lot of people are after, which is a feeling of more strength and stability? So I don't have the concrete answer for that one today. So thanks for stumping me, Julie. Give me something to look up in my next homework block. Julie just commented, yes, we're amazing creatures. Our body has ability to heal very well. I think I understand. Lori's question is, I think I understand then that healing continues after treatment ends. I've had PRP and treatments with shockwave and class 4 laser with 2 remaining treatments. Yes. So there's a very long tail off these treatments, which is kind of hard sometimes for patients to wrap their head around, because we're inducing a change in a short amount of time that's going to continue to remodel and bring more change for weeks, months after the treatment's completed. So when people complete treatment, the body is still, through those mechanisms we induce, going to continue to heal for a very long time. If we put PRP into tissue, it could heal for 12 weeks or longer. If we put stem cells into a body, it could continue to induce changes for as much as a year, we think. And with shockwave and laser, yes, the carryover effect of that can be many weeks after the treatment concludes. So if somebody does a run of 10 treatments twice a week for 5 weeks, they may still feel benefits coming through from that treatment for several weeks after that. So, good question. Gregory here's got a couple questions. Did I see on a slide that statins are detrimental to cartilage? No, it's actually interesting the other way. Statins have a mechanism to decrease inflammation in our vascular system, and they can have an anti-inflammatory effect. So they're not a indicated use of statins to treat joint pain, but mechanistically they decrease inflammation. And does Medicare cover any of shockwave or class 4 laser? Nope. Like many things that are awesome healing tools for the body that aren't detrimental and destructive, there's very little coverage, unfortunately, for these treatments right now with insurance plans. We just kind of ran through this to see if any of our payers, insurance plans are paying for any of these technologies, and they're not. So it's still in that category of wait and see, but I think we'll be waiting a long time for healthcare insurances to really, create a healing system of healthcare that supports the body's healing mechanisms rather than a reactive, just manage the breakdown and the chaos. I mean, I just think if people in the audience are holding out waiting for Medicare, well, I mean, don't hold your breath too long on it, because I don't know that it's ever going to come. I mean, I hold out hope some that our healthcare system in this category can change, but I've been in it for 20 plus years, and every year I'm just told, hey, things may come, and they never do. So I'm not trying to be a downer, but I'm saying, hey, if this makes sense, these treatments aren't out of the reach of most people to do. If we look at across the board what people are charging for laser alone, it's $100 a treatment. Shockwave maybe $100 a treatment or more. We did some market studies here that people are charging way more for lesser technology, and we're combining these treatments together for less than the price point of those, and separated in time. So you're getting a better synergistic effect. You're paying less for it. You're getting it all buttoned up in one treatment when we do it together. And then Tammy asked if PRP doesn't seem to make a lot of improvement, could this help? Yeah, it's a question of, the timing of the PRP, when it went in there, what effect did we see? Have we given enough time to see the effect? And then, yes, this is something that, as my protocols move along in my office, we're going to be integrating these much more than they're kind of a la carte add-on if you want tos, because the data is so good on the combination that most of our treatments are going to be combination therapies moving forward, where you're going to get some version of shockwave and laser as long as you don't have contraindications to doing the treatment. There's not too many in that category. I didn't get into it in the talk, but there's a few conditions where we can't use these, or if in close proximity to, say, pacemakers and other implanted devices, we can't be projecting shockwave at it. If you have metallic implants in your body, not always a great thing to project shockwave at. But you can use lasers safely for people that have had knee replacement in the audience or do have some kind of implant. You can use laser safely on those applications. If people have some bleeding disorders or arrhythmias, we really got to evaluate your case and make sure it's safe to be using these things. So these aren't benign tools. You're stimulating physiologic adaptations in the body, and you need to know what you're doing and the conditions people have to do it safely. So I kind of omitted those in our slides today, but that's kind of a wrinkle that we smooth out with patients in the office. Once we see them or once they're interested, we make sure that they have the condition we can treat and none of the conditions that would keep them from getting treatment. And then Judy, last question I see here in the chat is, how many areas can be treated at the same time? Well, that's a good question. I mean, it's a time-based thing, and typically in our office, we're treating 1 to 2 areas in the treatment session. If they're very small areas and very quick to treat, sometimes we can get to more than that. But it's hard to treat many parts at the same time and get enough energy into the tissue. When you're treating a lot of areas, you have to be somewhat selective and lead with the 1 or 2 top of the list problems, and that's kind of how we target it. But say if it's a thumb joint and it's a very small joint and you're treating on the thumb side, and then somebody has a wrist issue, you can kind of hop around to multiple places pretty quickly in the same treatment. But usually 1 to 2 is kind of the frame that we're using right now to treat people in a treatment session. Welcome, Greg. Can both knees be done at the same time? Yep, absolutely. As long as we don't have any reasons we can't go at them. If you don't have implants in there, then yes, very commonly, even when I'm doing cellular treatments, I'm doing both knees together if people have 2 arthritic knees. Same with this. So good question. Because here's the cool thing about it, and I put this lecture together fairly quickly, and now I'm seeing a couple of things that I omitted that I need to put into my next version in July, is that the cool thing about this versus stem cell and PRP, where we actually have to shut the patient down because they're kind of achy and inflamed, and we got to kind of get through that first 1 to 2 weeks, there really is no downtime with these treatments. So you can get treatment today and be back to activity tomorrow. And you could get a little bit of soreness from the shockwave, but the laser usually smooths that out. And so there's no downtime from activity. I don't have to take you out of activity in order to do the treatment, which is a big, big factor for a lot of my patients that want to do all day, everyday activity. And this is what's cool about it, is we get people further out and maybe away from cells, that we can continue to stimulate more healing with these tissue or these tools for the tissue without having to take them out of the activities they like doing. And the other cool wrinkle that I'll close with is they're using a lot of this for recovery now. So we look at major league pitchers that come off the mound after throwing, they ice the shoulder down as kind of the tried and true way, but now they're actually using the laser. So they'll ice them and laser them to help stimulate that regeneration recovery. So they're just accelerating the way the body can heal even faster and bounce back from that high demand they put on their shoulder to come out and throw, just as good a few days later. So we're not only using these for injury, but a lot of people are using these tools to enhance performance, enhance recovery from workouts, and bouncing back faster after workouts. So not a lot of people are coming in directly for that purpose. In my office, a lot of it's injury related, but again, there's kind of far-reaching applications for this, and a safety profile that's, as Julie shared here, non-invasive, no downtime, really minimal contraindications to be using this in patients. And to the question earlier, The only thing that stands in the way of, wide, conventional adaptation or adoption of this is really the coverage of it for patients. But, I don't know if it'll ever get there, but for those that are looking for different options, that was the goal of today's talk. And it's really why we've studied this for the past year and look to the best people to coach us in our office on how to do it and get the best technology we can, get the best protocols we can that are proven from another group that's used it for well over a decade, and then really just download those into our practice so that we can use them quickly with our patients. So if anybody has questions on this, feel free to reach out directly to my office. I'll put an email here in the chat just in case people can't locate us easy, but it's ORIGEN, Orthopedics, and Optimal Health. And that little QR code sitting there on the screen, you can scan and get over to our website. But if anybody has questions, they can always follow up just by emailing admin@origenortho.com. And we got great people on my team that can answer questions now around any of this new stuff we're doing. So with that, I'm gonna wish you all a great weekend. And Julie has one more comment. Highly recommend your YouTube with the interview. Oh yeah, so thanks, Julie. We'll just prompt some more things in my next talk. But those of you that are on YouTube, I have a YouTube channel. It's really easy to find. You just put my name in there, Dr. John Tait, and you'll find a bunch of videos that we're posting up educating people about this stuff, PRP, stem cell, just, hey, what are the natural things that the body can use and you can leverage to help your body heal, feel better, get back to the stuff you love doing faster. That's what we do in our practice. And we'll keep bringing in new exciting things and presenting little webinars like this as we bring them in. So stay tuned for July and August. Dates yet to be determined, but I have some more talks coming on some new things that we're incorporating into the practice here over the summer. So stay tuned, everybody. And thanks again for sharing your time with me on this Friday. And for those in Tucson, enjoy the heat. We'll see you.